you, Dr. Bhargavi. Thank you, Dr. Kumar, my close friend. So this is technically, it might be many times simple or many times it's difficult. But ultimately, what we are going to achieve at the end of the day after doing this pulmonary vein stenosis, we really do not know. And you just heard a lecture from Majini LV that a lot of things have happened in the recent past in the invention of the stents, but whether they are going to help us, let us see. I'll just show you two examples. One is relatively okay, simple. Another one is multiple issues. So then I think even after that, I don't think we'll have a proper answer for that. This child, 5-year-old, syncope for 4 months, cyanosis, shortness of breath, elsewhere diagnosed to have a possibly some other adult cardiologist has done the echo and shows that it is a pulmonary hypertension of unknown cause. But when we did the echo, it is a flow turbulence in the right lower pulmonary vein. That's what some other pulmonary veins are not visualized. Only one pulmonary vein we see that. That was the diagnosis. There's a pulmonary venous hypertension because of the venous occlusion, isolated one. There is a PFO, of course, and there is shunting right to left because of the severe PH. This is the ECG, like you see the RV strains, a severe right ventricular hypertension. This is the X-ray, like the right upper zone, almost it's like a whiteout lung, and that means that not much of vascularity. We are really at a very high pressure. Even if you see the X-ray, real X-ray, you're knowing that it's a classical pulmonary edema kind of picture. So this is the echo. We have two axes. One is the pulmonary vein, one pulmonary artery, another is the pulmonary vein. Transeptal puncture need not be done because there is a PFO here. It is very easy to enter the left atrium. So it was difficult to many times. First of all, we have to have a clear-cut idea that CT is a must. When you're dealing with this CT imaging, and you have to plan the procedure, how many pulmonary veins are patent, how many pulmonaries, what is the length of the occlusion, whether we can do something, whether really worth doing some small veins which are occluded are going to succeed. A lot of information we get on the CT. CT is a must of doing the CT. This is the picture so that we knew that what we are traveling. In spite of this, many times we have trouble. We may have to do a LUA phase angiogram to clearly mark the bony landmarks we may have to use to enter the pulmonary vein. And it's not very easy many times. If there is a flow, the wire will go. Generally, we use the coronary wires. Preferably, I use a whisper wire. In our unit, we use a whisper wire. That's a very workhorse for us. So this is the stenosis. It looks like. Once it is done, you try to serially dilate. You cannot put a bigger balloon. Many times you need to use a 1.5 balloon, 2 millimeter, 3 millimeter. They're very fibrotic. So this is the result after putting a stent. So the upper pulmonary vein, similarly, it was occluded, completely occluded. We didn't have a bony land. So we did a LEO phase and then we crossed with a slightly stiffer wire. We crossed with this Conquest Pro or something. I don't remember that we put a wire and use a renal stent here. So result is excellent. The PA pressure came down. A wonderful result. Just 2 weeks later, RV pressure was 30. Child was on follow-up medication with a aspirin and bit of diuretics for a short time. But believe me, the child came back within 1 year, maybe around 8 months or 9 months of time with a similar problem. So that we need to redilate once again. But this time it was easy. We know that where the stents are there, we need to poke them, and it was not completely occluded, so it was easy to do it. But it is a isolated. It is not de novo stenosis of the pulmonary veins without having an associated disease. It's not a post-operative one. In spite of that, this is the restenosis. I'm pretty sure that when this child will come back within a couple of months. This is another child, is a very tough child, 6-week-old infant with obstructed cardiac TAPVC, underwent repair 6 weeks later. Once again, severe pulmonary hypertension. My colleague, friend, Dr. Devanand did a Coles procedure. In fact, he's quite good in that particular procedure. He has got a largest data possibly of dealing with this procedure. The following images shows once again, you see the gradient across the pulmonary vein, right superior pulmonary vein, and all that. So the first time I was asked to do this. So then here, for some reason, the PFO was closed. Though he said that he has left a small PFO, it was closed. So we did a transeptal puncture in a 3.5 kilo child. So it is very difficult, a small, tiny heart. LA, please believe me that LA will be very small in these cases. It's a post-capillary hypertension. The LA will not be very big. It is not very easy to manipulate in a small infant or 2.5 kg, 3 kg. So this is the sheath, 5F sheath. Then put a delivery sheath of a 5F. This is not a guiding catheter. This is a thermo sheath. So it is so tough, this one. Dilated, pre-dilated back. Then subsequently after dilatation, the stent was stent deployment became easy. So I put 2 stents, one to the upper pulmonary vein and the lower pulmonary vein. The lower pulmonary vein, whatever I did not expand fully. So this is the result, reasonably good result. The child did well. Then couple of that time, then I had to resort to the transhepatic. The jugular, I did jugular once or twice. This is a transhepatic. So I tried because the venous access, multiple surgeries, 2-3 surgeries, and access both the right and left femoral vein is gone. Interjugular I tried, I don't have the picture here. So the interjugular vein after that, even interjugular vein is very difficult. Interjugular vein access was there, but this manipulating through the AST and getting into the pulmonary veins was extremely difficult. I had, when I did that through the jugular vein, I had a lot of difficulty. So I had to go through the transhepatic. And the radiology colleague, throughout this procedure, I think my colleague, the Kavya, was a great help to me. So she supported us. So these are transhepatic. So multiple procedures, multiple venous punctures, multiple surgeries. Really, is it worth it? We do not know, because the chance of the restenosis rate is so high. So we cannot avoid the restenosis, especially in pulmonary stenosis, pulmonary vein stenosis. It is rare and the prevalence is extremely rare. Less than 50% survive within first year of the diagnosis. The primary pulmonary vein stenosis, the progressive one, not be present at birth. Acquired multiple is secondary to most of the times of the surgery. In our clinical practice, we see predominantly during the TAPVC surgeries. Occurs in 10% of the post-operative surgery of the TAPVC. So approximately one of the patients with the primary PVS have associated cardiac defect. Clinical features like any right heart hypertension, right ventricular hypertension, cardiac failure. In adults, the acquired can happen because radiofrequency ablation with the electrophysiologists do during the pulmonary venous isolation using the radiofrequency catheters. This is not uncommon. I have seen that couple of them. And the radiotherapy I have seen one, after radiation, we have seen one of them. The diagnosis, the clinical suspicion, the echo and the X-ray will have some help. And usually the echo we can pick it up. Next is we need to do the CT or MRI. CT is quite good enough. The IVAS guided has been done, but I do not know. OCT limited use. OCT we don't use that pediatric cardiologist of much use. The CT certainly. This is the picture which I got from the wedge angiogram from Dr. Shweta and Dr. Nageshwar Rao. Say I took some photographs to show some of the pictures. This is how it looks like. So the prognosis, initial mean pressure, arterial pressure to be an independent predictor of the death in the pulmonary vein stenosis. Early diagnosis may lead to improved survival. I cannot say how long they'll survive. Mortality rate is 83% if do not treat them properly. The surgical procedure is still there. That's a pulse procedure. It's a preferred surgical method. Once again, I've seen plenty of cases coming back with the stenosis. I'm sure most of the people have the similar results. So pneumonectomy and all other things are very drastic procedures. So the catheter-based intervention is advantage is complementary to surgery and can be repeated multiple times, provided there is. We need to please remove that when you do the procedure, pulmonary venous stenosis, keep a large AST, a balloon dilate, and keep it a bigger balloon, and keep the IAS, intrathecal communication patent. That's a fundamental rule in the pulmonary venous stenting. Restenosis is universal. Limit options for further surgical approach. Might not allow future expansion to adult dimension. You can do, I can track the things, but that risk is there. The novel therapies of sonototherapy remains unknown. I do not have much idea about that. There's only literature. The hardwares, we need to have a knowledge of all these hardwares. We have to have a reasonably good knowledge of coronary hardwares like coronary wise balloons, peripheral cutting balloons are being used. Even I have used a cutting balloon in a couple of them. Drug-eluting stents, bioabsorbable scaffold might answer. I'm not very sure because ultimate pathology, what exactly it does, I do not know. We should have all the access ready for all these things. Conceptual puncture, we need to have a knowledge of how to skill of the conceptual puncture if there is no AST. So limited success with the catheter-based thing, immediate improvement is usually seen angiographically and clinically also. On the echo also, you see a good result. But how long? How to contract that high pressure balloons? Not very sure. You know, the high pressure balloons, our patients have come back. Cutting balloons for resistant lesions, it is an answer, but it's not very easy to speculate this. This is not going to cause the restenosis. There is a definite result using a balloon drug-eluting stent versus a metal stent. Certainly, the drug-eluting stent, if you extrapolate the data of, I know the pathogenesis is different in the coronary artery disease and here, but still I think the DES works well, reasonably well. Most of the stents of the coronary stents, what I have used, of course, we use only the DES nowadays. So only coronary stents available. As far as the problem of the downsize of the drug-eluting stents, we have only up to 5 millimeter. Some companies like Medtronic has got up to 5 millimeter, and Boston Scientific up to 5 millimeter. So medical management, so many drugs have been tried. Adults is almost always acquired. As I said, Balloon angioplasty can be done. Stenosis occurs in 50% of the year. To conclude, pediatric intraluminal stenosis is a chronic illness. Multimodality treatment is a strategy we should use. It's a team-based approach. Long-term results, pulmonary vein stenting, surgery and management are still optimal. Regular surveillance testing is critical. Thank you for patient hearing.